Hi, good evening, everyone. I'm Dr. Sangamitra, and on behalf of NNF and NOEL, I welcome you all to the third session of NOEL this week. And today's class is going to be on neonatal resuscitation, and we are going to start the session by sharp 8:30. So we have divided neonatal resuscitation into four parts. So starting with preparation and initial steps, followed by positive pressure ventilation, intubation drugs, and preterm resuscitation as a special scenario. So each of it will be a case-based discussion where a fellow will present the case and the expert will give their review in the end. So throughout the session, I request you all to mute yourselves. And if you have any questions, you can post in the chat box, which will be answered by the experts in the end. So we will start the session in another 5 minutes. And those presenting the first session can be ready with your screen shared. So the first session is on preparation for birth and initial steps. So this will be presented by Dr. Naga Mahesh. He is a fellow from RDT Hospital, Battalpalli. And the expert is Dr. Dasarath Ramaya. He's a pediatrician and neonatologist from the same hospital.
Good evening, everyone. Today, my topic of presentation is preparing for resuscitation and initial steps of newborn care. Coming to the case scenario, a 24-year-old primary mother, term gestation, has been admitted in active labor. Pediatrician was informed to attend the delivery. How to prepare? The preparation at the birth. Anticipation, the 4 pre-birth questions must ask is, what is the gestation age? Is the amniotic fluid clear? Are there any additional risk factors present? The perinatal risk factors increasing the likelihood of neonatal resuscitation is antepartum risk factors. Gestation age less than 36 weeks, gestation age greater than or equal to 41 weeks, preeclampsia or eclampsia, maternal hypertension, multiple gestation, fetal anemia, polyhydramnios and oligohydramnios, fetal hydrops, fetal macrosomia, intrauterine growth restriction, significant malformations or anomalies. No prenatal care. Intrapartum risk factors include emergency cesarean section, forceps or vacuum assisted delivery, breech or other abnormal presentation, category 2 fetal heart rate pattern, maternal general anesthesia, maternal magnesium therapy, placental abruption. Intrapartum bleeding, chorioamnionitis, opioids administration to mother within 4 hours of delivery, shoulder dystocia, meconium stained amniotic fluid, prolapsed umbilical cord. The fourth question is, what is our umbilical cord management plan? For most vigorous preterm and term newborns, the current evidence suggests that clamping should be delayed for at least 30 to 60 seconds. The personnel required, one qualified and skilled person in performing initial steps and PPV is required. 2 persons needed in the presence of risk factors. In case of extensive resuscitation, will likely require 4 or more qualified providers. Coming to the team briefing, assess the perinatal risk factors, identify a team leader, delegate the tasks to each and everyone, identify who will document the events, determine what is the equipment will be needed, identify how to call for additional help. Before starting the resuscitation, proper hand washing done by following the WHO steps. Resuscitation to be done under aseptic conditions. The equipment and supplies required for resuscitation is preheated radiant warmer, 2 clean warm towels, warm sheets, sheet for shoulder roll, plastic bag or wrap for less than 32 weeks, Delhi's mucus strap, 10 to 12 French, a suction catheter, suction machine 80 to 100 mmHg, stethoscope, air oxygen blender if available. Oxygen source with a flow meter capable of flow rate 10 liters per minute. Positive pressure ventilation device, a self-inflating bag of appropriate size with reservoir and oxygen tube. Term and preterm marks 0 and 1. 8 French orogastric tube with 20 cc syringe. Pulse oximeter, laryngoscope blade with 0 1 sizes. Endotracheal tube 2.5, 3 and 3.5 sizes. Measuring tape, estimate the nasotracheal length. Tape to secure endotracheal tube. Scissors, adrenal injections. Scissors, syringes required are 1, 2, 5 and 20 ml. Normal saline is 100 ml. UVC catheter of size 3.5 French and 5 French with 3-way stopcock. Supplies required for placing UVC catheter. TP's resuscitator and LMA mask to be made available if possible. The resuscitation instruments used in our department is, these are the resuscitation instruments used in our department. With all laryngoscopes, pre-vomit cover for less than 32 weeks, laryngoscope blades, ET tubes, self-inflating bags, pulse oximeter, CPAP with blender, oxygen, suction catheter, warmer. The most important step in the equipment check is testing a self-inflating bag. The 3 ways to check the self-inflating bag is squeeze the bag, feel the pressure against your hand, block the mask or gas outlet and squeeze the bag if the pop-up valve is moving. By closing both mask and valve, look for the leak. We'll see the both normal self-inflating bag and self-inflating bag with leak with demonstration. First step, second step, third way to check. The self-inflating bag with leak is in the second bag there is a leak of air is present. After checking the equipment check, coming to it, antenatal counseling team briefing after equipment check, after the delivery of the baby, the 3 questions are, is it term gestation, good tone, breathing or crying? If all the 3 questions are yes, infant stays with mother for routine newborn care. Warm and maintain the normal temperature, position airway, clear secretions, if needed dry, ongoing evaluation. The routine care is skin to skin with mother, provide warmth, skin to skin, cover with the warm towel, clear the airway if needed, monitor the vitals. Next, but after if the 3 questions, term gestation, good tone, breathing or crying is no, then we'll go for the warm, dry, stimulate, position the airway, suction if needed. These are the 5 initial steps. Provide warmth, dry, stimulate, position the head and neck and clear the secretions. These are the, if the answer is no, we will take the baby immediately to the warmer and we will try and stimulate the baby. Then we will, the dry and stimulate should be limited to drying an infant, rubbing the back and soles, no flicking of the soles. The baby is kept in the sniffing position. Then the clearing of the airway, no routine suctioning. Clear the airway if the baby is not breathing. Baby has poor tone, airway is obstructed, mouth followed by the nose. Not more than 5 centimeters in the mouth, not more than 2 centimeters in the nose. 10 French to 12 French suction catheter, 80 to 100 mm of Hg pressure is required. In case of meconium stained amniotic fluid, we will see the vigorous babies. Vigorous baby stays with the mother, oral and nasal suction if needed. In case of non-vigorous babies, resuscitated in the warmer. Initial steps including the oral and nasal suction is performed. Routine intubation and endotracheal tube suction is not recommended. After this, the assessment of initial steps is check for the respiration. Is there any apnea or gasping? If there is any apnea or gasping, we directly go for the positive pressure ventilation. If there is a normal respiration, then we will assess the heart rate. Heart rate is assessed by auscultation by 6 seconds and multiplied by 10. or through a echocardiography or a pulse oximeter. If the heart rate is above 100 and there is a normal respiration, then if the baby has labored breathing or the persistent cyanosis, then we will go for the oxygen supply and we will connect for the CPAP. The oxygen is administered through the assessment is done with the pulse oximeter. The sensor is connected to the right wrist for the preductal saturations. The term neonates require 21% of oxygen. Preterm neonates require 21 to 30% of oxygen. The oxygen delivery methods are free flow oxygen and through TP's resuscitator. The target preductal oxygen saturations are at 1 minute, the target should be there 60 to 65%, at the 2 minutes 65 to 70%, by 3 minutes 70 to 75%, by 4 minutes 75 to 80%, 5 minutes 80 to 85%, by 10 minutes 85 to 95%. These are the target saturations should be maintained. Thank you.
Thank you, Mahesh. So, as Mahesh told, the most important thing is asking in asking questions to the obstetrician. We should never forget in the risk factors whether it is a twin pregnancy or a singleton pregnancy. So that information can be missed if we don't ask specifically. They may also forget informing the pediatrician. And another important issue is antenatal scans. In a hurry of doing emergency section, they may not check antenatal anomaly scans. And if once it happened, a baby, mother was taken for emergency section, and baby delivered, and baby is not maintaining saturations. And we thought everything is normal and for 4 5 hours, but we could not save the baby. Ultimately, we came to know that antenatally, fetus had complex heart disease. Even obstetrician missed on that aspect, and the attending pediatrician missed on that aspect. Apart from this, in the equipment check, as Mahesh rightly demonstrated, we should always check for leaks by closing the gas outlet and even in the this pop-up valve. Then only we can come to know whether there is a leak or it is a leak-proof self-inflating bag. And one more important aspect is while checking the laryngoscope, the bulb should be tight. Otherwise, sometimes some accidents may happen while we are intubating. These things I wanted to bring to the notice of all fellows. If any further inputs, seniors can add. Sheshgiri sir, Ramprasad sir.
If anybody has questions, they can post in the chat box so that they will be answered by the expert in the end. So thank you, Nag Mahesh and Dasrath, for such a short and detailed session. So the next session will be on positive pressure ventilation. So to present on this, I welcome Dr. Akhilesh, who's a fellow from Andhra Hospital, Vijayawada, and the expert is Dr. Bujata. She's a consultant neonatologist at Andhra Hospitals. So over to you, Akhilesh.
Good evening, ma'am. Good evening, one and all. I am Dr. Akhilesh. Today I am presenting about the positive pressure ventilation in NRP. This is a case of female named Dhanakasu, 30 years old, pregnant female, presented to a gynec department with the complaints of leaking pervaginum since 6 hours. With the antenatal history of priming with 38 weeks, regular antenatal checkups done at a referral hospital with a TIFA scan of normal, with no history of gestational diabetes and hypertension and no medical illness complicating pregnancy. 2 doses of TT was taken and NST showing decreasing variability. Hence, mother was taken to emergency cesarean section and neonatal team was informed. Parents are counseled about the need for resuscitation, if at all. Natal history. Male baby delivered. Time of birth noted at 11:30 a.m. with weak cry at birth and cynosed and limp. Cord was cut immediately and baby has transferred to resuscitation cord. Initial steps of resuscitation was done. Placed in a radium warmer, dried the baby and removed the wet linen. Stimulate the baby by rubbing on the back. Shoulder rods were placed. Suction of mouth and nose was done as secretions were present and the baby was resuscitated. Baby had gasping respirations and heart rate was checked. It was 80 beats per minute and PP was started with a self-inflating bag at the rate of 40 to 60 beats per minute. On the count of breathe, 2, 3. Simultaneously, nurse was asked to connect the pulse oximeter probe onto the right hand. OT staff was called for the help and was asked to note the time. After 15 seconds of PPV, heart rate was reassessed and heart rate was 70 beats per minute and corrective steps were taken. That is mask adjusted and the baby was repositioned with the proper extension and or sniffing position. PPV was continued for 5 breaths and adequate chest raise was looked for. As there was no adequate chest raise and suction was done and open mouth and PPV was resumed and continued for 5 breaths and reassessed. Again, there was no adequate chest raise, inflating pressure was increased and intubation was considered. And the staff was asked to call the neonatal consultant for help. As there was adequate chest raise after effective PPV was continued for 30 seconds and baby was reassessed. Now baby heart rate was 120 beats per minute and was having spontaneous respiration with the peripheral cyanosis and preductal saturation of 65%. Baby was started on oxygen support, taking care to required preductal target saturations and baby was shifted to NICU for the post-resuscitation care. As baby was having grunt with a Downey score of 6 and baby was started on bubble CPAP. On FiO2 of 40% with a PEEP of 6 and hemodynamics of the baby was stable at a heart rate of 160 beats per minute. Peripheral cyanosis improved and NIBP shows of BP of 60 by 38 mmHg. Cry tone activity of the baby was normal. Cord gas shows with a pH of 7.23 and CO2 of 50 mmHg and the base exit of -10. Lactate of -3. Course in hospital. USG lungs and chest X-ray search 2 of right side pneumonia. Sepsis screen was sent at 12 hours of life and CRP was increased to 12 and CBP was normal. Blood cultures was sent and baby was started on IV antibiotics. Functional echo was done, shows mild PAH with a PFO of 2 mm with a left to right shunt. Baby was off respiratory support by day of life 3 and field was started on 2 hours of life and no convulsions during the hospital stay. Baby was given antibiotics for 7 days for early onset of sepsis, that is pneumonia, and baby was discharged on day 8 of life. Discussion. This is the algorithm we usually follow. If baby had any apnea or heart rate below 100, immediately we have to start with positive pressure ventilation. Assessment of heart rate. If any had apnea or heart rate less than 100 or a baby was in gasping, we have to start positive pressure ventilation. And measuring of heart rate with a stethoscope for 6 seconds and multiplying with 10. Positive pressure ventilation. Newborns who would not breathe within first 60 seconds after birth are persistently bradycardic, that is heart rate less than 100 beats per minute, despite appropriate initial actions including tactile stimulation, and may receive positive pressure ventilation at the rate of 40 to 60 beats per minute. In a newborn infants who was gasping or apneic with a within 60 seconds after the birth, who are persistently bradycardic, that is heart rate less than 100 despite of appropriate initial actions and including tactile stimulations, PPV should be provided without any delay. A newborn infants who require PPV, it is reasonable to use peak inflation pressure to inflate the lungs and to achieve rise in heart rate. This can be usually achieved with the peak inflation pressure that is of 20 to 25 centimeter of water. Occasionally, higher peak inflation pressure is required. In newly born infants receiving PPV, it may be responsible to provide positive pressure and expiratory pressure. excessive peak if inflation pressure are potentially harmful and should be avoided. And this is the positioning of mask. So this is the right posture to maintain effective PPV. Effective PPV is done with on account of breathe 2-3, followed by rise in heart rate. Assess after 15 seconds. If no rise in heart rate, chest do not move, chest do not moving, ventilation corrective measures should be followed. That is MR SOFA. Second assessment of heart rate after 30 seconds of effective PPV. MR SOFA, mask adjustment and that is reapplying the mask. If necessary, consider two-hand technique. Reposition of airway. Place the head neutral or slightly extended and try PPV for 5 breaths and reassess the chest movements. Suctioning of mouth and nose. Use of bulb syringe or suction catheter. Open the mouth and lift the jaw forward and try PPV again and reassess the chest movements. If still chest movements doesn't present, pressure should be increased. An increased pressure is of 5 to 10 centimeters of H2O increments and with a maximum of 40 centimeters of H2O. And try PPV again and reassess the chest movements. If still there is no chest rise and alternative airway should be preferred. That is endotracheal tube or with a laryngeal mask. Back and mask ventilation using room air. Give 5 ventilative breaths and look for the chest rise. And if there is no chest rise, then take the corrective steps.
इसकी वो जो मैंने खाई थी ना तो वो हाँ सर्दी बहुत ज्यादा है कब से ये तो 15 दिन से है सर्दी इसको.
Adjust a mask to assure airtight seal. Reposition of head to open the airway. Suction to remove the excessive secretions. Increase the pressure by squeezing the bag to get the visible chest rise. And this is the method of ventilation, that is at the rate of 40 to 60 per minute. There is a breathe 2-3 and breathe 2-3. Recommendation for oxygen administration during neonatal gestation. In term and late preterm newborns, that is 35 weeks or more gestation length, receiving respiratory support at birth, in the initial use of 21% of oxygen is reasonable. In preterms or newborns less than 35 weeks of gestation length, receiving respiratory support at the birth, it may be reasonable to begin with 21 to 30% of oxygen, with subsequent oxygen titration based on pulse oximeter. In term or late preterm newborns, that is 35 weeks or more gestation length, receiving respiratory support at the birth of 100% oxygen should not be used because it is associated with excessive mortality. Use of oxygen during ventilation. Term baby with a gestation age more than 35 weeks. Weeks of ventilation should be started within the room air. A baby with a gestation age less than 35 weeks, ventilation should be started with oxygen concentration of 21 to 30%. Air oxygen blender should be available at the possible all the birthing points. If not possible, way to ventilate the baby with oxygen attached to the ventilation bag without a reservoir, so that it may provide oxygen concentration of 40% to the baby. And this is the TPS resuscitator. Thank you.
Thank you, Akhilesh. I'll just stress on the important points regarding the positive pressure ventilation. As far as our neonatologists are concerned, this bag is our magic wand. I used to call it as magic wand whenever I teach my fellows or postgraduates. So only 4 or 5 things we should consider are, first, when you go to the labor room, just make sure that your bag is functioning. Just don't leave it to the nurse. If it's a senior in charge, okay, that's okay. But make sure your bag is functioning, and how to check the functionality of the self-inflating bag has already been explained. Okay, make sure your bag functions well. Second thing, when to start PPV, that has to be within the 1 minute. If the baby is apneic or gasping, or your heart rate is less than 100, or if both are there, the heart rate is more than 100, the baby is having respirations, but your target saturations are not as per the chart, then also you can start your PPV. Okay. So check the function, when to start PPV. It has to be within the first golden minute. That is the reason we are going through this NRP again and again, because this is a very life-saving thing. You need not know intubation also, but a positive, effective PPV can save lives really. And third thing, you go to the labor room, you know when to start and how to give, when to start PPV. Now, how to give PPV is important. So whenever you cover the face with the mask, make sure the chin is cuffed first. So you apply the mask with the chin cuffed first and then take on to the over the mouth and the nose, so that you completely circle your mouth and the nose. Make sure that your eyes are, the baby's eyes are not being compressed in that. Okay, so how you cover the face of the baby is also important. And fourth thing, what is important is the seal what you provide. So whenever you do that, you hold your mask with this C shape. And now NRP, whenever we teach, what we say, that better seal can be obtained by holding onto the stem of the mask. Okay, so usually what happens, the leak happens at the cheek, that is where usually leak happens. So when you apply the pressure on the stem, okay, you are holding your face mask like the C position, and just compare. Next day, you go back to your neonatal resuscitation corner and just check on this your mannequin. Okay, so there is a difference when you hold it as C and hold it on the stem. Effective seal can be provided when you hold it onto the stem of the tube and the mask. Okay, so the way you deliver your positive pressure ventilation is also important. Okay, that is the fourth thing. And fifth thing is when to start oxygen. No oxygen. So if you're a term baby more than 35, you want to resuscitate, just don't be in a hurry. You don't have an oxygen source. You can start in room air. If it's a less than 35 weeker, blender if possible, yes. If no blender, just remove your reservoir from your bag so that you won't be giving 100%. You will be restricting your FiO2 percentage concentration to around 40%. So basically these are the 4-5 things I just wanted to highlight. Function, check the function of your bag, when to start your PPV, how to place your mask, how to get the good seal. Just apply put your hands onto the stem of the bag and mask. Then when to start your oxygen source. So then then again, when you reassess, keep on reassessing. Give one breath, don't keep on reassessing. If you are giving good effective PPV, when is that effective PPV called? Effective PPV is when your heart rate is rising. You had a 40 heart rate, your heart rate becoming 60, your heart rate becoming 80 and all. Yes, you are giving good PPV. Continue for 30 seconds and then reassess. No, if there is no increase in heart rate, just look at the chest. Are you giving effective PPV so that there is an increase in the chest rise? If there is increase in the chest rise, again continue. Just see if the heart rate rises. Continue for 15 seconds and see if the heart rate rises. If it is not rising, then apply all the MR SOPA things. Like again, readjust the mask. Somewhere there is seal. Somewhere the seal is not tight. And then reposition the baby. Maybe your neck is not that extended. So give a bit of extension. Give that sniffing position to the baby. If it is not done, go for the other things. Clear your airways, suction. Open mouth. Open mouth is recently, according to 2024, open mouth ventilation is not that highlighted. But yes, if what our aim should be, you have to have a clear airway to give effective PPV. Even if with that it doesn't work, give for 5 breaths. It doesn't work, go for increase in the pressure. The amount you are squeezing the bag, increase their pressure. Even if that is not working, now you need a person who is trained in advanced NRP and you can come and help you out with intubation. Just call for help. Okay. So these are the basic things in PPV. Thank you.
Thank you, Mahesh and Bujata. I think, Bujata, there's a question in the chat box for you. Experience of using LMA in resuscitation.
Yes, if there is any, you already have a cleft palate or a severe cleft palate or cleft lip babies being delivered, LMA definitely works, because there recently 4-5 months back we had a baby there. We feel difficult intubation. Then yes, we can. But hardly we get come across these babies. That baby was quite dysmorphic with other congenital anomalies also. But small cleft palate and cleft lip, yeah, we can do with intubation. But where there is a very large cleft and where there will be difficulty intubating, your LMA definitely helps.
Thank you, Pujata. So, going on to the next session, it is about intubation and drugs, the next step in neonatal resuscitation. And to discuss this, we have Dr. Bhavya Sri. She's a fellow from Medicover Hospitals, Vizag. And the expert is Seshagiri sir. He is from Lotus Hospitals, Vizag, and sir is also our NNF president for the state of Andhra Pradesh. So over to you, Bhavyasri.
రెడ్డి సార్ చూసాను సార్ అయినా అలా ఏడుస్తుంది తగ్గట్లేదు ఏమి పాపట్లేదు
Good evening. Really,
Bhavyasri, can you share your screen?
ma'am, I'm trying to do that, ma'am. 1 second. Is it visible now, ma'am?
No, it's not visible. Have you logged in from two different devices?
No, ma'am, one single device, ma'am.
Bhavya, are you able to see this share option?
Yes, ma'am. I'm trying to share the screen.
Open your file first onto your desktop. Then
Yes,
it will
ma'am.
be easy for you.
There.
Just
Is
close
it?
all the screens. Open your file onto your desktop or place the file on your desktop. Then once you see the share button, share your desktop.
I'm doing it directly through the Zoom, and it's not happening, ma'am. So,
No, you can't do through Zoom. You want to share the screen on your desktop. There'll be a logo, no, share screen option. Monica, can you help her?
is it now visible, ma'am?
No, it's not visible.
Dr. Bhavya, you can do one thing. You can share your PPT to either of us, Dr. Sangamitra or to Dr. Akhilesh, so they can share the screen for you. You
Yes,
can
ma'am.
WhatsApp
I'm
them if
sure.
possible.
Yes, ma'am. I'm WhatsApping it to Sangamitra, ma'am. Ma'am, I've shared it.
I didn't get your WhatsApp. Okay, I got it, Bhavya. So
Okay.
Akhilesh will share his screen, okay?
Okay, ma'am.
2 minutes, ma'am. I'm doing.
Yeah. Akhilesh, are you able to do it?
Yes, ma'am. 2 minutes.
Or I can ask Monica also to do it.
Yes, ma'am. If you share the PPT, I can share the screen.
Yeah, I shared it on WhatsApp to you, Monica.
Yes, ma'am. I'll check it.
Good
Okay,
evening.
Bhavya, you can do it.
Yes, ma'am. Good evening, one and all. Today, my topic of presentation would be on intubation and drugs. I am Dr. Bhavyashri from Medicover Hospitals, fellow in neonatology, Visakhapatnam. So I would like to start the presentation with a case scenario where we were called to attend an emergency C-section due to umbilical cord prolapse with fetal bradycardia. We assessed the perinatal risk, prepared the personnel, team briefing was done, preparation of equipment and supplies was done. Test the function of bag and mask for ventilation. Ma'am, could you please move the slide, ma'am? Next slide. So we went to the OT. The baby is born. Baby is not breathing. Initial steps of resuscitation were done. The heart rate is less than 100. In spite of giving IPPV for 1 minute, there are no spontaneous breathings. So we started intubating the case with correct size ET tube. Bag and tube ventilation was done for 30 seconds. The heart rate is still less than 60. So we called for additional help. We increased the FiO2 to 100%. We started chest compressions and ventilations. After 60 seconds, we assessed the heart rate, which was less than 60. In pulse oximeter, there's no signal picking up. So we prepared for umbilical venous catheterization. Estimated baby weight was 3 kg. So ET dose of 3 ml of 1 in 10,000 adrenaline given. Continued coordinated chest compressions and ventilations for 60 seconds. Excuse me, ma'am. Could you please move to slides, ma'am?
Can Tejashri, can you control the screen because your screen is
Next slide, next slide, next slide, next slide, next slide. Next slide. So intubation with correct size tube is done. Bag and tube ventilation for 30 seconds done. Assessed heart rate, which is less than 60. We called for additional help, increased FiO2 to 100%. Started chest compressions and ventilations, and after 60 seconds, assessed heart rate, which is less than 60. Pulse oximeter, no signal. Next slide. So we prepared for umbilical venous catheterization. The estimated weight of the baby was 3 kg. So ET dose of 3 ml of 1 in 10,000 adrenaline given. We continued coordinated chest compressions and ventilation for 60 seconds. Assessed heart rate, which is less than 60. Pulse oximeter, no signal. So umbilical venous catheter was secured and 0.6 ml of adrenaline was given by umbilical vein. And assessed heart rate after 60 seconds. Heart rate is still less than 60. Pulse oximeter has no signal. And baby is still pale. So we continued coordinated chest compressions and ventilation. Next slide. We checked for history of blood side, history of blood loss. There was antepartum hemorrhage. So we have given 10 ml per kg bolus, 30 ml NS in 5 minutes by UVC. So assessed heart rate after 60 seconds, heart rate started picking up. It is above 60. So pulse oximeter shows 67% stats. We discontinued chest compressions. We continued PPV for another 30 seconds. Assessed heart rate is now 100 beats per minute. Pulse oximeter shows 80% stats, and there is no spontaneous respiration. So we continued positive pressure ventilation, and oxygen concentration was adjusted as per saturation targets. Heart rate is now 130 beats per minute. Pulse oximeter now is showing 92% sats. Some spontaneous respiration established. So we supported the baby with positive pressure ventilation and supplemental oxygen as per target oxygen saturation. And we shifted the baby to NICU for post resuscitation care, that is to provide cardiorespiratory support. So the next slide. The indications for endotracheal tube intubation are heart rate less than 100 beats per minute in spite of giving effective positive pressure ventilation, or if there is requirement of surfactant administration or any suspicion of diaphragmatic hernia, and also to improve the efficacy of ventilation if positive pressure ventilation is prolonged, it is highly recommended to intubate a case before starting chest compressions. So these are the supplies required for intubation. A laryngoscope with extra set of batteries, laryngoscope blades with different sizes, 0, 1, 00 according to the gestational age of the baby. ET of different sizes, 3, 3.5, 2.5. Tape and scissors for fixing the ET tube, and measuring tape to determine the nasal tragus length. Next slide. Selection of ET tube is based on the weight and gestational age of the baby. If the gestational age is less than 28 weeks and below 1 kg, we usually intubate with 2.5 mm tube. Gestational age of 28 to 34 weeks and weight 1 to 2 kg, we intubate with 3 mm tube. And more than 34 weeks, we intubate with 3.5 mm tube. So for intubating, like any case, we should know the upper airway anatomy. So we should be lifting the epiglottis so that the vocal cords are visualized. And the figure A shows the correct position where the site of airway is clear after you lift the tongue with your laryngoscope. So in the next slide, I'm going to play a video where the procedure of intubation is clearly explained. Could you please play the video? So according to the gestational age, the depth of insertion is given. And with a measuring tape, one can measure the nasogastric tube, nasal tragus length, add 1 centimeter to it. With your left hand, intubate the case. So one can visualize the airway like this. Lifting the epiglottis, we can visualize the vocal cords. And from the right side, we insert the tube. Once the tube is inserted, we check for chest rise and equal air entry. The next slide. Next slide. So in this picture, we can see the measurement of nasal tragus length from the middle of the nasal septum to the tragus of the ear. Add 1 centimeter to the measurement. That gives you the depth at which the ET is to be fixed. We usually, when there is sudden deterioration after intubation, we usually check for these things. Can be easily remembered with a mnemonic dope. If there is endotracheal tube displacement, or if there is any obstructed endotracheal tube, pneumothorax or equipment failure, there can be sudden deterioration after intubation. So indications for chest compressions are even after 30 seconds of effective ventilation, the heart rate is still less than 60 beats per minute. So we start giving chest compressions. The person providing chest compressions should be standing at the head end of the baby, and the one providing PPV should be standing on the side of the table. And this picture shows that the site of the chest compressions, where the thumbs are placed over the lower third of the sternum and the hands encircling the chest. And the next picture shows the gray area here shows the compression area just below the imaginary line joining the nipples. And this picture shows the depth of chest compressions, approximately 1/3 of the anterior-posterior diameter of the chest. So here is a here is a video that plays correct chest compressions. So here the team leader is assigning duties to one another. So the person providing chest compressions is standing at the head end. The one providing positive pressure ventilation is standing on the side. And chest compressions are provided at a rate of 90 per minute with a compression ventilation ratio of 3:1. Each cycle of 3 compressions and 1 ventilation should get completed in 60 seconds. So 3 and 2 and 1 and breath, that's the rate at which it is given. After 60 seconds, we evaluate the heart rate, and the heart rate is still less than 60 seconds. We quickly assess the following. If the chest is moving with positive pressure ventilation, if the ET is in place, if the rate of ventilation to compressions is correct, or if the depth of compressions is correct, or if the inspired oxygen concentration is 100%. If the answer is yes to all the above questions, we should prepare for securing the umbilical venous access and administer the drugs. So the medications used in resuscitation are adrenaline and volume expanders. Adrenaline is indicated if heart rate is less than 60 beats per minute, even after at least 30 seconds of effective ventilation, followed by 60 seconds of coordinated compressions ventilation with 100% oxygen. The concentration used is 1 in 10,000. So we prepare a stock solution of 9 ml NS plus 1 ml of adrenaline in the same order to avoid overdilution. The route of administration, IV is preferred. IV by peripheral vein is not recommended. If umbilical venous access is not feasible, then the next best method is intraosseous route. Endotracheal route is less effective. Dose of adrenaline is 0.2 ml per kg of body weight of the stock solution that we prepared for IV or intraosseous route. For endotracheal route, it is 1 ml per kg of body weight of the stock solution. So next, repeat the dose of adrenaline every 3 to 5 minutes. We reassess after every 60 seconds for the heart rate. Consider hypovolemic shock or tension pneumothorax if the baby is not improving. Volume expanders are used if the baby is not responding to the steps of resuscitation. Check for signs of shock or history of any acute blood loss. Volume should not be routinely given in the absence of shock or history of blood loss, as it may lead to volume overload and will further worsen cardiac output. Volume expanders commonly used in normal saline and PRBCs. 10 ml per kg over 5 to 10 minutes is usually given. If there is no improvement, one more dose can be considered. So how long can you resuscitate? Like when to stop resuscitation? The heart rate the heart remains absent for 20 minutes after birth. With the consent of the parents, we can stop resuscitation. Thank you.
Thank you, Bhavyashri. Over to you, Seshagiri sir.
Okay, I think she has covered everything, Sangamitra. I think it's only repetition, whatever I tell again. Can I share a few slides for the benefit of the fellows?
Sure, sir. Sure.
I'm permitted to share now.
Yes, sir. You can share now your screen.
Okay. Friends can now see. Yeah, is it visible?
Yes, sir. Sir, can you please switch on your slideshow?
Okay. Yes.
Orange. Yes, sir.
Yeah, now it's visible.
Yes, sir.
Yeah, everybody, we are discussing about assessment, preparation, plan, teamwork. This is very important for the all aspects of resuscitation. Again, preparation is important, planning is important. Ultimately, the teamwork which achieves the goal. Okay, I think everybody is highlighting this, no issue. And coming back to intubation, intubation is sometimes it is very easy and sometimes it becomes very difficult. And as a fellows, we need to do even if it is difficult, we should not fail. That is one important things. Where difficult situations are there, few important things like here it is extremely preterm infant. Sometimes it becomes very difficult, and we need to have another person also to help us. Apart from that, there is anticipated difficulty where you can see abnormality from the outside, so that you can see there will be some difficulty, like especially when you have some syndromic things and when the baby is other having some other abnormalities, definitely you can anticipate the difficulty in airway and management or intubation. Then probably you can get the help of the senior person. If it is suddenly, sometimes happens also, sometimes unanticipated, like laryngeal atresia, tracheal lesions, and some webs and all. These things also you should have something in your mind, that not that it is always failed intubation is not your problem. There is some problem, real problem that might be there inside. So these are the important causes one can face with the difficulty intubation. So many causes are there depending on the site of obstruction. Apart from that, when you see first, there is a grades of observation, grade 1 to grade 4. Grade 1 is entirely the cards are visible very easy. Sometimes they are not visible, that's grade 4. That is the grading of the airway assessment. This is one technique very important for our fellows. That is when you are not able to see properly, that if it is grade 2 or grade 3 assessment, then probably you can do this burp technique. Burp is a backward, upward, and right pressure of the trachea, where sometimes the bigger babies, like 2-3 kilos babies, definitely this technique will help to see the vocal cords properly. So this technique everybody should be aware as a neonatal fellows. Apart from that, normal anatomy. Apart from normal anatomy, they should also familiar with other things like laryngomalacia, laryngeal clefts, and varicular cyst, congenital galactic web, all those things. At least they should know about the things, and they should be able to identify immediately and they can, if they know what is the problem, then they can find a solution. So abnormal things also, apart from normal anatomy, abnormal things also they should be familiar. Okay. Apart from that, there is LMA. Madam told Bujata about LMA, and some bigger babies definitely where intubation is difficult. LMA is definitely useful. And apart from that, now iGel is available for just a cost of around 1 to 2,000 rupees. iGel is the one thing which probably many pediatricians are not aware, but it is easily available on the net now. You can order and get for just rupees 1,000 rupees. And the difference between LMA and iGel is the one which made of a thermo level. It just accommodates because it is molds itself because of temperature of the inside body, and you need not inflate it. That is the main difference. And also it fits properly compared to LMA. So one should get familiar with this LMA and iGels. And also when you use this LMA and iGel, apart from fixing the ET, you should also get familiar with the fixing of this LMS and iGel. And apart from that, recent things are available like video laryngoscopy. You can take the help of in difficult intubation, which are available with the cost of around 1.5 lakhs. And those things also can be utilized where it required. There's a few important things which I wanted to highlight. And if any questions are there, probably we can take at the end of the session. Over to you, Sangeeta.
Thank you, sir. So the next session is on preterm resuscitation and how different it is from term resuscitation. So to present this, we have Dr. Tejasri. She's a fellow from Rainbow Hospital, Vijayawada. And the expert joining her is Dr. Ramprasad sir. He is a consultant neonatologist and pediatrician at Rainbow Hospital, Vijayawada. And sir is our secretary NNF for the state of Andhra Pradesh. So having the president and secretary, I would also like to inform you all that we have NeoCon 2025 at Andhra Pradesh, that is Vishakhapatnam. So you can register early and avail the opportunity and present your research. So over to you, Tejasri.
Good evening, everyone.
Is screen visible, Sangamitra?
Yes, sir. Screen is visible, sir. Please switch on your slideshow.
Yeah. In PDF register. I think.
Yes, sir.
Good evening, everyone. My case discussion was a primary gravid of mother of 28 weeks of gestation with twin pregnancy. Antenatal period was twin pregnancy, eclampsia, PPROM, liquor was clear. She underwent emergency LSAS under general anesthesia. And the risk factors in this case was prematurity, preeclampsia, eclampsia, IUGR, and intrapartum risk factors like emergency cesarean section and maternal general anesthesia. Next comes the pre-birth questions. These 4 pre-birth questions are regularly asked in NRP. Apart from this, what additional questions we ask for preterms like any signs of intraamniotic infections, steroid coverage done or not, magnesium sulfate coverage, any usage of antibiotics. Next comes who should attend the delivery. As this is the high risk case and it was a twin delivery, we need 2 teams with separate equipment for each baby, 2 qualified individuals with at least one having advanced resuscitation skill. Next comes preterm prenatal counseling. This is very important in preterm delivery. We counsel the parents before the delivery regarding the immediate post-delivery complications and the requirement of the long NICU stay. And this pre-resuscitation team briefing is the same as earlier discussed in the previous session. What additional equipment we needed for preterm delivery? For temperature control, we use plastic bag and wrap and thermal mattresses, PPV equipment, TP's resuscitator, oxygen and air source with blender, preterm face mask, LMA, intubation equipment like 2.5 to 3 size ET tube, 000 size bed with laryngoscope, for monitoring cardiac monitor with chest leads and pulse oximeter, transport incubator with ventilator, inform to NICU to prepare bed and for equipment. What precautions we do while resuscitating the preterm newborn. Handle the baby gently, avoid the Trendelenburg position of the newborn, avoid high pressures during a PPV, use pulse oximeter and blood gases to monitor and adjust the ventilation and oxygen saturation. Do not rapidly infuse the IV fluids. All these precautions decreases the chances of IVH in preterm babies. First, as we consider, first twin male baby was delivered, cried immediately after the birth. How we manage? Which is the best suitable cord management in this case? Is this delayed cord clamping is good, or umbilical cord milking and immediate cord clamping? According to AHP AAP focused updates and level of evidence to BR for preterm newborns less than 35 weeks who do not resuscitate, delayed cord clamping for more than 30 seconds can be beneficial compared to early cord clamping. A study was conducted in Jason et al. Delayed cord clamping for more than 30 seconds, there is a reduce the risk of mortality and intraventricular hemorrhage and blood transfusions. And what is different in initial steps compared to term babies? Avoid drying steps and use plastic wrap and thermal mattresses to cover the baby without drying. What respiratory support we should start in preterm? Do you provide oxygen immediately or CPAP in delivery room and shift immediately to NICU and start on CPAP? Early CPAP is preferred over the intubation because it reduces the requirement and duration of mechanical ventilation and reduce surfactant requirement and reduce BPT and maintain the saturations as per target saturations. And which FiO2 to start with? 21%, 30%, and 60% and 100%. According to AHA and NRP recommends, we start FiO2 for preterms less than 35 weeks of gestational age. According to European resuscitation guidelines, more than 35 weeks, 21%, 32 to 35 weeks, 21 to 25%, 28 to 32 weeks, 25%, less than 28 weeks, 30%. Recent evidences are contradictory. And this is the JAMA Pediatrics and Systemic Review and Individual Participant Data Network Meta-Analysis. They conducted study on 1,055 infants from 12 studies. Resuscitation with high FiO2, initial FiO2 associated with significant reduced mortality compared to low FiO2s and intermediate FiO2s. The effect on morbidity was inconclusive. Next, we give immediate KMC. Immediate KMC is skin-to-skin contact immediately after birth before the stabilization and exclusive breast milk feeding. This immediate KMC reduces the 25% of lower neonatal mortality compared to conventional group. Next. KMC can even be given in unstable infants. This is a skin incubator. Next, baby stabilization of the preterm baby. Baby cried immediately after birth. Delayed cord clamping was done. Shifted under the warmer with a warm blanket covered under plastic thermal mattresses. Start CPAP and attach the pulse oximeter and cardiac monitor for maintaining the vitals. Counsel the parents regarding the condition and transport in pre-warmed incubator. Consider immediate KMC more than 25 weeks. And golden hour of management. This is the first hour after the postnatal life. Immediately after the delivery. In golden hour, we manage these are the components in golden hour of management, include antenatal team briefing and counseling, delayed cord clamping, prevention of hypothermia and thermoregulation, respiratory support optimization, optimization of hemodynamics, early nutritional care, prevention of hypoglycemia, infection control, records and monitoring, communication with the family. Next, twin to female baby is delivered, not cried immediately after the birth. Cord management plan. What is a cord? According to recommendations, for preterm infants between 28 to 34 weeks of gestation who do not require resuscitation and whom TCC cannot be performed, cord milk will be reasonable. And recommendations of AHA and AAP 2023 guidelines, any baby who is vigorous, delayed cord clamping is at least for 30 seconds. For non-vigorous babies, more than 28 weeks of gestation, intact cord milking was done. Less than 28 weeks of gestation and early cord clamping was beneficial. Next step, intact cord milking done. Next, shift the baby under the radiant warmer, received in plastic bag and temperature probe was attached. Initial steps like warm, do not dry the baby, stimulate and position, suction if needed. Still no cry, go to the next step. If baby was apneic and heart rate is less than 100, start PPV and attach a pulse oximeter and cardiac monitor and assess still heart rate is 100 BPM and go for adequate ventilation corrective steps. consider ETT and laryngeal mask airway, and attach the cardiac monitor. Less than 100 BPM, still ETT, intubate the baby and start chest compressions and prepare for UVC line. And then next 60 BPM, start drugs IV adrenaline, and still not improving the heart rate, consider hypovolemia and a pneumothorax. These are the devices used in for primary ventilation: self-inflating bag, TP's resuscitator, flow-inflating bag. According to systemic review done on administration of ventilation at birth, early use of TP's resuscitator shortened the duration of PPV and lowered the risk of BPD. And recommendations used for PPV, it is beneficial to use TP's resuscitator, particularly for preterm infants. Any other options available other than this intact cord resuscitation? Ventilation before in this technique, we do ventilation before the cord clamping. It improves the cerebral oxygenation for the baby. These are the intact cord resuscitation technique. Concurrent birth trauma. This is a scenario 2 we discussed earlier. Female baby not tried immediately after birth. Flaccid tone. Obstetrician hold the baby in warm blanket, give gentle suction, tone poor and not breathing, intact cord milking done, cut the cord and shift the baby under the resuscitation team, shifted under warmer, received under cling wrap and temperature probe attached. Still baby was limp, not respiratory support, start PPV with TP's resuscitator, pulse oximeter was attached to preductal limb. Heart rate is less than 100, chest not moving with PPV, ventilator corrective steps will done, poor response to PPV, endotracheal intubation, FA gradually adjusted as per target saturation, counsel the attenders and shift to NICU, consider the early rescue at surfactant. Important care during preterm birth was first preparation and delayed cord clamping more than 30 seconds, thermoregulation with the cling wrap and thermal matrices, and respiratory support, delivery room CPAP, PPV with a TP's resuscitator, saturation targeting, gentle handling of the baby. Thank you.
So summing up of whatever Dr. Tejashree was explaining, basically preterm delivery, every preterm resuscitation is a challenging situation. And if you see, you can broadly divide preterms into three main things. One is late preterms starting from 32 to 36 plus 7, moderate preterm from 28 to 32, and extreme preterm less than 28 weeks. These less than 28 weeks are the very fragile group where we require a lot of expertise. We require one senior neonatologist and two senior staff members. The equipment should be pre-checked, everything. The team should be ready before the delivery. If it's a twin, we should have two members, two teams here. Now, for 28 weeker, we will have delayed cord clamping. If child is stable, we can do delayed cord clamping. Cord milking is not advisable. Thermoregulation is very important thing which differs from the term babies. Thermoregulations, we have to take them in a cling wrap, keep the hat. See, the temperature which you maintain from the delivery room to the NICU is very important. It's one of the quality indicator. Less than 1 degree centigrade decrease in temperature from the delivery room to the NICU, it carries increased risk of mortality by at least 25 to 30%. So that's why maintaining the temperature is very important. So thermoregulation is very important. First is delayed cord clamping, thermoregulation. Third one, TP's resuscitator. Now latest guideline says is you have to use 30% FiO2 for these less than 28 weekers. So use 30% FiO2, and remaining steps using the other resuscitation techniques are is same. Difference is you have to, if you are at all you are going to intubate this child, intubate and give surfactant for these kids in the delivery room. That's very important. So this is the 28 weeker what you have to take. So delayed cord clamping if feasible. Otherwise, immediate cord clamping, cord milking is not done. Thermoregulation is one important. TP's resuscitation FiO2 of 30% and intubation and surfactant is required. Immediately shift the child to NICU in the warmed incubator. Maintain the temperature is important. Now the second category of moderate preterm where you have 28 to 32 weeker. Here, delayed cord clamping for 30 seconds, for more than 30 seconds is feasible. Cord milking is feasible. But avoid if possible. Cord milking is feasible. Thermoregulation, as we use cling wraps, cap, it is very important in 20 to 32 weeks also. And resuscitation, intubation if required, or TPs resuscitation, if you can manage with TPs and early CPAP, delivery room CPAP, that is well and good. Most of these babies will do with CPAP. They don't require intubation and surfactant 20 to 32 weeks group. And last group of late preterm 32 plus, that they are very well managed. Usually they don't require special thermoregulation. Routine for term babies, what we use, you can use this dry warmer, dry warm towels, those can be used. Delayed cord clamping is advisable for more than 30 seconds. And FiO2 in these two categories of late preterm and moderate preterm, you can start with 21 to 30%. Or as European guidelines says, is 25 to 30%. Only thing is, for less than 28 weeks, start with FiO2 of 30% if required with TPs. I think these are the few important things what you have to take. Gentle handling is very important, and presence of a senior neonatologist and senior staff is very important in handling these preterm babies, especially intact survival, because the moment if you intubate, and if you can't intubate, sometimes their cerebral vessels are very fragile. There are chance of intraventricular hemorrhages in especially in 24 to 28 weeks. You have to take a one-to-one call on, you have to counsel the parents, you have to tell the long-term prognosis. So till 28 weeks, it's okay, but 24 to 20, especially 24 to 26 weeks, these are the very, very fragile babies. So if the parent doesn't have any other kids and they have IVF, this one, yes, we do resuscitate 24 to 26 babies, but the morbidity, mortality may be higher, according to Western studies also. But these require delayed cord clamping if feasible only, otherwise immediately cut, take the cling wrap, intubate and give surfactant, shift to NICU. Gentle golden hour management is very, very, very important thing which take care of this 24 to 26 week prognosis. Thank you. Over to you, Sangamitra. And I request all of you to register for the National Neocon 2025, which we are going to be in Hotel Novotel at Visakhapatnam. Thank you. Thank you. Over to you, Sangamitra.
Yes. Thank you, sir. So with that, we come to the end of today's session, and basically the right preparation is the one thing that is required, and half the resuscitation is done if you prepare right. And the next thing is PPV is the most important primary skill that you need to learn. And preterm resuscitation, always know what extra you need. And apart from all this, no matter how many times each of us can tell you about the steps, or we keep drawing the flow diagrams and answer the questions, I think the most important thing is to have practical hands-on experience. So attend as many deliveries as possible, so that you get more experience in resuscitation and you become more confident, because each baby is different and each resuscitation comes with its own challenges. So thank you all, and we will meet you Thursday next for the next session of NOEL. And uh, thanks to all the experts, Dr. Dasarath, Bujata, Seshagiri sir, and Ramprasad sir, for sharing your valuable time and your review on neonatal resuscitation. So thank you all and good night.
Thank you, Sangamitra.
Thank you.